I'm Dr. Sonia Anand. I'm a professor of medicine and vascular medicine specialist at McMaster University in Canada. Today, I would like to review which patients benefit most from dual pathway inhibition. The benefit of dual pathway inhibition is highest in patients who have polyvascular disease. That means vascular disease that affects more than one arterial bed. We observe that patients who have two or more vascular beds affected, such as coronary artery disease or peripheral artery disease, or in some cases, both cerebrovascular disease, coronary disease, and peripheral artery disease, that the risk of major adverse cardiovascular events increases with the increasing number of vascular territories affected. So, in summary, the highest risk patients of all our atherosclerotic vascular patients are those who have polyvascular disease. In the COMPASS trial, in which we enrolled patients with CAD or PAD, we asked this question. Although patients with CAD or PAD benefit from dual pathway inhibition, perhaps we could find the highest risk patients within this patient population. And to do that, we created a modified risk scoring system to count up the number of risk factors and subdivide our patients into high-risk patients versus lower-risk patients. Independently, we used a second method called the Classification and Regression Tree Analysis, or CART, to ask the computer to pick out the independent highest risk groups for major adverse cardiovascular events and limb events. Both of these ways to identify high-risk patients identified similar patients. Using the modified REACH risk score, we observed patients with two or more vascular beds affected, patients with low eGFR or a history of heart failure were the highest risk patients. And with the CART analysis, we identified patients with two or more vascular beds affected, history of heart failure or diabetes represented the highest risk patients. So altogether, the factors of polyvascular disease, low eGFR, history of heart failure, or diabetes help you identify the highest risk vascular patients who you should consider to treat with dual pathway inhibition without too much additional analyses. Here I show the number of events prevented per 1,000 patients treated with dual pathway inhibition over aspirin alone. And you can see that the two or more vascular disease beds affected group, or polyvascular patients, we prevent the greatest number of events per 1,000 patients treated compared to those patients who do not have polyvascular disease. Similarly, we observe 44 events prevented per 1,000 patients treated who have a history of heart failure, 36 events prevented for 1,000 patients treated in patients who have a low eGFR, 31 events prevented per 1,000 patients treated in patients with a history of diabetes, and 33 events prevented per 1,000 patients treated amongst patients who have any one of these high-risk features. So the low-hanging fruit amongst our patients with CAD or PAD are polyvascular disease patients, patients with a history of heart failure, patients with renal insufficiency, or patients with diabetes. These represent the highest risk groups who benefit the most when we use dual pathway inhibition. We put together a meta-analysis of the two trials in which dual pathway inhibition was compared to aspirin alone, namely the COMPASS and the Voyager trials. And here you can see a graphical display of the events prevented per 1,000 patients treated, as well as the events caused, in this case, major or severe bleeding. And this demonstrates for you when we put all the PAD patients from COMPASS together with all of the PAD patients in Voyager, we're preventing more MACE or male events than major bleeds caused, and only one severe bleed, such as fatal or critical organ bleeding, amongst the patients who experience bleeding. So we have a clear net clinical benefit in favor of dual pathway inhibition over aspirin in all PAD patients, and a very similar result in patients who have symptomatic lower extremity PAD, a subset of the overall PAD population from the COMPASS and Voyager trials. And there are very few severe bleeds caused. So again, we have shown the net clinical benefit favors dual pathway inhibition versus aspirin alone in patients with peripheral artery disease. When we think about how to convey risks and benefits to patients, we need to consider a shared decision-making model where we sit down, we understand the patient's values and preferences, and we try and clearly communicate the benefits of dual pathway inhibition compared to the risks. It's very important to have the risk-benefit discussion with our PAD patients and convey to them in terms that are understandable that the overall data favors the use of dual pathway inhibition compared to aspirin alone at preventing very important events such as myocardial infarction, stroke, death from those causes, as well as major adverse limb events, most notably major vascular amputation. So how can we improve patients' adherence to this management strategy? Again, conveying the risks and the benefits in a very clear manner helps a patient with decision-making. On the benefit side, we can convey the dual pathway inhibition lowers the risk of MACE as well as male and cardiovascular death. On the risk side, although there is an increased risk of major bleeding, there is no increased risk in the most severe types of bleeding. There's minimal burden to taking the medication once a patient gets into a routine, and the cost burden is something to consider with each of our patients depending on their ability to pay. Thank you very much for your interest in peripheral artery disease and dual pathway inhibition.